Hi, everyone. My name is Hope Avalone, and I'm the Senior Manager of Patient Education Programs here at the Lymphoma Research Foundation. And it is my great pleasure to welcome you to our webinar, Update on Chronic Lymphocytic Leukemia and Small Lymphocytic Lymphoma. During today's webinar, you'll hear from two excellent speakers, and you'll have an opportunity to ask questions. You can submit those questions at any time through the Q&A box at the bottom of your screen, and we'll address as many as we can after the presentations today. And as a reminder, this webinar is being recorded. Also, at the end of the program, you'll be prompted to complete a program evaluation, and we ask that you complete this evaluation because we do incorporate your feedback into future programming. Before we get into the presentations today, I'd also like to share with you a few brief words about our organization. The Lymphoma Research Foundation is the largest nonprofit organization that focuses specifically on lymphomas and chronic lymphocytic leukemia. Our mission is to realize the promise of science to eradicate lymphoma and, of course, to serve the community that's touched by this disease. And all of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. And in addition to today's program, the foundation has many other programs and services available for you. So we offer both in-person and virtual programs so that you can continue your learning throughout the year. I'd like to specifically highlight our lymphoma talks, which are coming up in Los Angeles in August, in Houston in October, and in Minneapolis in November. Our lymphoma talks are weekday in-person programs, and they include 3 breakout sessions, including one session specifically on CLL. So to view the agendas and the speakers for these programs and to register if you'd like, you can always visit lymphoma.org/programs. And in addition to our patient education programming, the foundation has a wide range of support services. So our helpline has master's level trained staff who can provide individualized information on all subtypes of lymphoma, as well as treatment options, clinical trial navigation, and connections to resources such as financial assistance. And we also offer a peer support program called the Lymphoma Support Network, which can connect patients and care partners with others who have been through similar experiences for emotional support. And the foundation also offers comprehensive disease guides and fact sheets, which can be ordered or downloaded for free on our website at lymphoma.org. And please look for us on YouTube as well, where we spotlight different lymphoma subtypes, including CLL, and treatment options. And finally, I'd like to highlight our Spanish language resources if you would find those helpful or if you know anyone who might. I would also like to take a brief moment to thank our program supporters. Thanks to their generosity, we're able to host programs like today's webinar. But for now, we have a wonderful program planned for you today with 2 expert speakers, Dr. Deborah Stevens from the University of North Carolina and Dr. Jacob Soumerai from Massachusetts General Hospital. I'm honored to introduce our first speaker, Dr. Deborah Stevens. Dr. Stevens is the director of the Chronic Lymphocytic Leukemia and Richter's Program at the University of North Carolina Lineberger Comprehensive Cancer Center. She's also an associate professor in the Department of Hematology at the UNC School of Medicine. And last but not least, she is actually a former grantee under the Lymphoma Research Foundation Scientific Research Mentoring Program. Dr. Stevens, we're so happy to have you back for this program, and I will now turn the talk over to you.
Well, thank you very much for the kind introduction and welcome everybody. It's really great to have everyone here today to learn more about CLL. And I'm very honored to be talking with you today about just a general CLL overview and talking through some of the potential first treatments that you might receive for CLL. An overview of the topics I'm going to be covering today. I will talk in general about chronic lymphocytic leukemia or small lymphocytic lymphoma. I'm going to talk about the current treatment options in frontline therapy and the new treatment approaches. And then, of course, we'll have plenty of time at the end for questions. So first, I wanted to start with just a general CLL overview. And this is kind of going back to the basics and what is CLL or SLL. Basically, when I think of it, it is a blood cancer. And when I think of blood, I want to think about the three main solid components of blood to explain what's happening. So first we have red blood cells, and these are the cells that help to carry oxygen. And if you're low on red blood cells, that means that you're anemic. We also have platelets, and these are the cells that help the blood to clot. If you have low platelets, that's called thrombocytopenia. And then most importantly for our purposes today, we have this whole group of cells called white blood cells, and they're very important for fighting infections, a really important part of the immune system. And of course, CLL is a cancer of a type of white blood cell. And especially you all have probably seen your own labs, and you know that there's this list down at the bottom of all the different types of white blood cells, which are listed here. But for CLL, lymphocytes are what we're going to focus on today. So lymphocytes are normally there to help you fight infections, especially viruses. And so a lot of people ask me, how is CLL or SLL diagnosed, and how do I know that my doctor has made the correct diagnosis? And I will say that the diagnosis is typically made just with a blood draw. Sometimes it comes with a lymph node biopsy, but what we're really looking for is we're looking for abnormal lymphocytes, so abnormal white blood cells that have specific markers on them. And we generally will be able to tell this through something called flow cytometry. And the markers that we're really looking for are little markers that live on the surface of the cancer cells. For example, CD5, CD20, CD23, and CD19. They will also have, likely we'll say kappa or lambda light chain restricted, and these are some important markers. CLL is negative for CD10. So if the CD10 is expressed, that's not counted as CLL. There is significant effort put into making sure that this is not mantle cell lymphoma, which is another common non-Hodgkin lymphoma that also expresses some of these markers. And in that case, we want to know that it is negative for cyclin D1, or there is something called a FISH test that can be done in the blood for translocation 1114, and it must be negative. Sometimes your doctor might say you might not quite have CLL because you don't have enough of these abnormal white blood cells. And for an official CLL diagnosis, the number of these CLL cells must be more than 5,000 in the blood. If you have less than 5,000, you might have a condition called small lymphocytic lymphoma, or you may, in the absence of any lymphadenopathy or other symptoms, you might have something called monoclonal B-cell lymphocytosis, which is kind of a precancer condition, a precancer that may turn into CLL at some point. Again, thinking about diagnosis, a lot of people have come to me and they've just had a blood sample taken and they say, well, don't I need some sort of invasive testing in order to diagnose CLL? And really, the majority of the time you do not. But some of the things that can happen around the time of diagnosis or the time of needing treatment are a bone marrow biopsy, a CAT scan, or a PET scan. Again, not most of the patients that I diagnose these things are not required. They might be just used to give me additional information. So a lot of people ask me what's the difference between CLL and SLL, and I don't really love the term SLL because it's small lymphocytic lymphoma. CLL is chronic lymphocytic leukemia, and I think people are often confused, well, do I have leukemia or do I have lymphoma? And so again, I mentioned that CLL includes having a high white blood cell count, so more than 5,000 of these cancer cells circulating around in the blood. And SLL, typically you would have a white blood cell count less than 5,000, but you're seeing cancer cells, for example, if you do a lymph node biopsy, you have an enlarged node or an enlarged spleen, and any biopsies are going to show these abnormal cells. I don't really like it because it actually looks the same. You look at it underneath the microscope, so it's the same thing, it's just in a different location. And so when I'm talking with patients about it, I usually talk about it like a couch. So your cancer cells are like a couch, and your body is the house. And so thinking about it, if you have a couch and you move it to a different room in your house, it is still the same couch. And so that's why, it's really the same thing, different location. There may be some minor differences just related to where these cells like to live, but for our purposes, we actually treat these two things the same. And I think it gets a little bit confusing because the staging system for CLL is different than the staging system for small lymphocytic lymphoma. And so you might have been told that you have a stage 4 small lymphocytic lymphoma, but you actually only have a stage 1 or even 0 CLL. And I think that the CLL staging system is a lot more accurate for this particular type of cancer. So one of the things that I like to do at diagnosis is just give an idea of people how that they can predict outcomes. I think of these things as really important prognostic outcome markers. For example, how can I predict how soon it will be until you need treatment? How quickly I'd expect the disease to divide? And I'm going to talk just a little bit about each of these things. There's something called an IGHV mutational analysis, something called a FISH panel, next generation sequencing, beta-2 microglobulin, and karyotype. And beta-2 microglobulin, this is just a lab test that's done. You can usually get the results back pretty quickly. The other ones are more specialized tests that are drawn from the blood typically, and they do take some time to come back. So importantly, there's something called an IGHV mutational analysis. This tests for a gene that is normally mutated when immune cells are produced in the body and different antibodies. About half of patients with CLL have an unmutated copy of this, half have a mutated copy, and this does not change over time. So it comes from that initial blood cell that becomes a cancer cell, and so that doesn't change over time. And unmutated typically is expected to divide a little bit more quickly. And if you look back at really older references now, they would say, someone with unmutated IGHV might have a shorter survival. Well, that has changed a lot with our novel therapies that we have that we're going to talk about today. So I really caution people if they're going to look up, what their markers mean. They're really using modern references because the older references can make people feel unnecessarily scared about their prognosis. A FISH panel is often done, and basically what we're looking at is we're looking at spots on your chromosomes. And chromosomes are genes that are organized into 23 pairs. And so, for a normal, in the case of a male, you would have 46 XY, and a female would have 46 XX. When you're looking at these. And they look like this little graphic up here that has 4 arms. And one side is one chromosome, and so a paired chromosome is 2 of them. And the shorter arm is called the P arm, and the longer arm is called a Q arm. And when we do this FISH probe, we're really looking for, most of the time, we're looking for 4 important markers. So we're really just pinpointing a few things that might be important in terms of prognosis. These things are things like deletion of 13q, trisomy 12, deletion 11q, and deletion 17p. And we're really just trying to assess risk and trying to decide at a time when treatment is needed, what treatment is going to be the best treatment for you. There's also something we do called a CLL next generation sequencing panel, or sometimes people just do specifically something called a TP53, a mutational analysis. What TP53 is, it's a tumor suppressor gene, and so you might guess that it suppresses tumors, and it's a guardian against mutations in the genes that are caused by cancer. So when this gene is mutated, it no longer effectively suppresses any type of cancer growth. And so in CLL and actually many other types of cancers, it creates more resistance to treatments. Not a reason to panic, but it is something to know about, and your doctor will likely choose your first therapy based on whether you have this mutation or not. And I also think it's important when selecting subsequent therapies. So what I like to do with these prognostic markers is I like to put it all together into this risk factor that takes both these lab factors that we're checking, and it also takes some clinical factors. And so again, deletion 17p or TP53 mutation is in there. The serum beta 2 microglobulin, which is a lab test that generally results fairly quickly, the IGHV status, the stage, and people's age. And so you can see how many points that they're delegated there. What I like to do with this is I like to look at it and I like to say, what is your overall score and what's the risk level? Not because it helps me in terms of predicting survival, but more so because it helps me to predict how long it might be until you need a treatment. And so what I've listed here over on the side is the percentage of people with CLL with these risk scores who might require treatment after 5 years. And so low risk, only 15% of people require therapy, which is a pretty low number. When you get into the 2 to 3, after 5 years, you're getting close to about half of people needing treatment. And when you get into the 4 or higher category, the majority of people are going to need some kind of treatment within 5 years. Again, when these risk factors were originally determined and when this risk score was determined, they actually did provide information about overall survival. But again, I am pretty cautious when people are looking up this information because these risk factors were calculated even now a little bit before we had all of our new therapies. And so I don't really focus on that survival standpoint because I think those results are outdated. But what is not outdated is the chance and the timing of when you might need treatment. And so I mentioned when you might need treatment. It's a little bit hard to wrap your mind around sometimes that CLL is a type of cancer that you can be diagnosed with and not actually require treatment. And that's because there's, many different treatments have been tried in early intervention and none so far have shown any benefit. So what we do is we say that you only need to be treated if you have active disease. And so that means, maybe you have anemia or you have low platelets because of your CLL. Maybe you have an enlarged spleen that's causing a lot of symptoms like feeling full quickly or pain under the left side of your rib cage. Or maybe you have lymph nodes that are, large in your neck or somewhere else and are causing discomfort. And then we do talk about things called B symptoms, and your doctor probably has asked you about all of these things before, but these are also things you should notify them if you experience them. So if you're losing weight and you're not planning to lose weight, and that is a significant amount of body weight, so 10% in the last 6 months. If you're having fevers when you don't have any infection, and these are lasting more than 2 weeks at a time. If you have night sweats multiple times in a month without any evidence of infection, and usually I think of these as drenching night sweats, like you have to wake up and change your clothes or change your sheets. And usually I ask, how frequent are they coming, and are they more frequent than they were 3 months ago? And progressive symptoms might indicate you need to be treated. And then severe fatigue. I will say that almost every patient that I've ever seen with CLL has some level of fatigue. And when I think about severe fatigue, I think, is this preventing you from doing your daily activities and preventing you from, living your life and doing the things you really want to do? And so, we've called this watch and wait. Some people have said, would it be watch and worry because we have this cancer and we're not treating it? But again, right now, no treatment has been proven to lengthen survival when given early. But I am going to be talking about a clinical trial later on that does look at, a new way to look at is doing treatment earlier a good idea for CLL. And so when you were diagnosed, or maybe you've already started some sort of treatment, I think it's really important to understand the goals of CLL treatment. And one important thing is there's really no cure for CLL yet, but there are lots of people doing lots of great research to try to change this. So hopefully that will be changed at some point here in the near future. A bone marrow transplant has been deemed as curative potentially. However, they have a lot of side effects and are really not recommended or even options for a lot of folks who have CLL. And so what I say is the main goal is to actually put people into remission. And remission is not the same thing as cure, because remission means that there's no evidence of active CLL, whereas cure means there's no evidence and it's never coming back. So remission means there's no evidence of active CLL, but we know it probably will come back at some point. And we want to keep people in remission for the longest period of time possible. So you might hear your doctors talking about complete remission, partial remission, progressive disease. So complete remission means you have totally normal blood counts, no enlarged lymph nodes or spleen. A partial remission means that you have decreased the size of the lymphocytes, the lymph nodes, the spleen by 50%. Stable disease, of course, means there's no change, and progressive disease means there's new areas or worsening disease. I'm not going to talk too much about this, but I might get some questions about this. I just wanted to comment on something called minimal residual disease or measurable residual disease. This is something that is sometimes done at the end of therapy to assess response. It's designed to detect very small levels of CLL. It can be done by multiple different methods. The most common ones are flow cytometry or next generation sequencing. And if you say MRD negative or MRD undetectable, it means we can't detect the disease. But that doesn't mean, again, that the disease is cured. It just means it's so low we can't detect it at the current time. And CLL patients who have undetectable MRD after certain treatments, so things that we call time-limited treatments, have been shown to have a longer survival and a longer time off of treatment. And so it is important. It's not always checked. I wanted to mention it because I'm sure there might be some questions about it. I want to talk in general about current treatment options, and then I'll get more specific about the ones that we most often recommend. But in general, just wrapping your mind around that this is a blood cancer. And so general cancer treatment options, surgery is not an option. Radiation is very rarely an option, and I would say almost never. And so chemotherapy or targeted therapies are the usual choice because this goes into the blood and we're treating all of the blood. We have classic chemotherapy, immunotherapy, or targeted agents that I'm going to talk about. When I talk about classic chemotherapy, I think about drugs called like fludarabine, cyclophosphamide, bendamustine, chlorambucil, pentostatin, and we really actually hardly ever, and I might even say never recommend these types of treatments anymore, just because we have so many better options. And also there's just a lot of side effects that come along with these short-term and long-term side effects. Immunotherapy is something we commonly use. A classic example of immunotherapy are drugs called monoclonal antibodies. And basically what they're trying to do is they're going to go in and they're going to try to specifically target something that lives on the surface. Remember, I talked about those surface markers that we see on CLL cells. And the most common ones we use are drugs that target CD20. And this would be rituximab or obinutuzumab. There's also an older drug called ofatumumab that we don't use quite so often anymore. But really where the big story is now is with targeted therapy. And the goal of this is to avoid killing normal cells and go directly after the cancer cells. These are drugs that I'm going to talk in more detail about, but just to give you some examples of those, these are ibrutinib, acalabrutinib, zanubrutinib, pirtobrutinib, and venetoclax. And so kind of a big group here, you heard me say a lot of them that ended with ib, like ibrutinib or acalabrutinib, zanubrutinib. These drugs are called Bruton tyrosine kinase inhibitors. And basically what they are doing is they're blocking the cancer survival signals. And this is called the B cell receptor pathway. And so what I think of it as like you're taking the gas out of your car. So the cancer cells can't go anymore because they don't have any of this gas anymore. Again, these drugs are ibrutinib, acalabrutinib, and zanubrutinib. They are approved for all patients with CLL. And there's a novel drug, which I'm not going to talk too much about in my part of the presentation because I'm only really talking about frontline therapy. But know that this is one of the most recently approved BTK inhibitors. And they are approved for patients whose CLL has relapsed after 2 prior therapies, including one of these other BTK inhibitors and a drug called venetoclax. So venetoclax is another pill This is a drug, it's based on something called a BCL2 inhibitor. And the concept of this is that cancer cells express something called BCL2, and that causes them to live longer. So the cancer cells just don't ever want to die. And so when you block that BCL2, then basically the cancer cells will remember that they need to die. And so it's a way to kill off the cancer cells. Venetoclax is approved for all patients with CLL in combination with an anti-CD20 monoclonal antibody like rituximab or obinutuzumab. These two drugs that I've talked about, so the BTK inhibitors and the venetoclax combinations, BTK inhibitors and venetoclax are both oral pills. They just have really different strategies. And so with continuous therapy, with the BTK inhibitors, their goal is really disease control. They want to create a prolonged remission, but you do need to take these drugs long term. So do you need to take them forever? Is sometimes a question that my patients ask, and really the answer is maybe. I mean, if it works forever, it's not causing any side effects, we don't come up with something different, then maybe you do take this long term or maybe even forever. This is kind of a different strategy, would be fixed duration, which is the venetoclax potential strategy. So when used in the frontline setting, venetoclax and obinutuzumab is given for a total of 1 year. So you do 1 year of therapy. The goal is to try to eliminate as much disease as possible, maybe even get you to undetectable, measurable residual disease, and then have the holiday off of drugs with prolonged remission, with a potential option to use these drugs again, which I'm not going to cover, so I'm just talking about frontline therapy. But, when we think about this, basically these options are things that should be presented to you at the time of therapy. You can go over any potential side effects, and, the strategy, continuous versus fixed duration, the cost of the treatments, and decide which is the best option for you. And we take into consideration all of those risk factors that I just that I talked through at the beginning of the talk. We take into consideration, personal preference and other medical problems that you might have. And so it's really a big discussion when people start therapy. We have, really great options. I didn't mention here, but one option that I'm a huge fan of is also clinical trials, which I'm going to talk a bit about here coming up. So when we think about new treatment approaches, there are lots of them out there, but I wanted to kind of boil it down to what I think is most important and what's closest to coming to the clinic the soonest. And really what we're looking at are different combinations of these new drugs. And kind of the theory here is you want to pick 2 or 3 of these good drugs and combine them. So you can take a Bruton tyrosine kinase inhibitor, you add a BCL2 inhibitor, and then maybe an anti-CD20 monoclonal antibody therapy. Potential advantages of these, maybe these are deeper, longer lasting responses. The goal is to shorten the treatment length, especially with the BTK inhibitors, since those are continuous therapies. So I just wanted to highlight a couple of examples of ongoing clinical trials. There's a clinical trial called the Captivate study, and it pairs a BTK inhibitor called ibrutinib with a BCL2 inhibitor, venetoclax. Based upon this study and some others using this combination has been approved in Europe, in Canada, and some other locations, but not in the US because there were a few concerns about safety. So some subsequent trials with drugs like zanubrutinib, which is considered to potentially be a safer BTK inhibitor, plus sonrotoclax, another version of BCL2 inhibitor. This study is fully accrued, and we're really awaiting data for this to tell us, is this a great regimen? Is this regimen better than what we have currently? For example, one of the trials that are going on now, it pairs it puts it up against obinutuzumab and venetoclax. We also have the Amplify trial, which was just recently presented and published, and that includes a BTK inhibitor, acalabrutinib, plus the BCL2 inhibitor, venetoclax. In this clinical trial, there was an arm that just had the 2. There was also an arm that had the 3. And based upon these data, It is a recommended regimen to use acalabrutinib and venetoclax plus or minus obinutuzumab, which can be recommended for some people based on NCCN recommendations. However, it is not yet approved by the FDA. The other kind of exciting thing that I want to talk about is another trial looking at early treatment. This is the S1925 Evolve study, and this is specifically for people who are newly diagnosed within the last year and a half. They have these higher risk genetics. I mean, I talked about the CLL IPI score, so any CLL IPI score of 4 or higher would qualify for this if you're within a year and a half of diagnosis. These patients cannot meet any criteria for treatment, so no symptoms or other low blood counts, and they are randomized to either receive immediate treatment with obinutuzumab and venetoclax or delayed treatment with venetoclax and obinutuzumab. This is a national study led through the SWOG group, and it's open at many, many locations across the country. And so definitely a good trial to look into if you are within the category of newly diagnosed and found that you have some higher risk characteristics. So I really wanted to keep it broad and do just an overview of CLL and SLL, talk about current options in Frontline, and then new approaches. And with that, I will turn it over to my colleague.
Thank you so much, Dr. Stevens, for getting us started. And I just wanted to remind everyone that if you do have questions, please submit them through the Q&A box on your screen, and we'll get to them at the end of the presentation. We'll take as many as we can with the time that we have left. But for now, I'm so thrilled to introduce our next speaker, Dr. Jacob Soumerai. Dr. Soumerai is a hematologist, oncologist, and clinical investigator at Massachusetts General Hospital Cancer Center, as well as an assistant professor of medicine at Harvard Medical School. And he was also part of the Lymphoma Research Foundation's clinical research mentoring program. And we're thrilled to have him back for another patient ed program. So thank you so much, Dr. Soumerai, and I'll turn the talk over to you.
Thank you so much for inviting me to participate in this program. It's always a pleasure to do anything with the Lymphoma Research Foundation. And thanks to Dr. Stevens for kicking us off with talking about sort of the initial workup approach and first-line treatment of these patients. I'm going to take over and talk about second and third-line therapy, and then focus a little bit as well on managing selected side effects with some of these novel agents that we now use. So today's objectives are to discuss first the approach to second-line treatment, and next, of course, third-line therapy, and finally to discuss some of the selected treatment side effects. One thing just to highlight is that I'm really not going to focus on clinical trials here. However, clinical trials in CLL are always a reasonable and very appropriate option if there is an appropriate clinical trial that is really in line with your priorities and for which a patient is potentially eligible. So let's kick it off and start with second-line therapy. When we think about the approach to second-line therapy for patients with CLL, the first and most important question is, well, what did he get before? And why was it stopped? And so gathering information about the prior treatment course is the most critical information that we obtain. And there's fundamentally three different groups of patients here. There are patients who have received continuous therapy with a BTK inhibitor, like acalabrutinib, zanubrutinib, or ibrutinib, as Dr. Stevens has highlighted. There are patients who've received time-limited therapy. These are treatments that are started and stopped with a subsequent treatment-free interval off of therapy, and ideally, hopefully without evidence of disease. And the FDA-approved option right now is venetoclax and obinutuzumab, but we also now have an NCCN compendium recommended option in acalabrutinib plus venetoclax with or without obinutuzumab. Again, these are time-limited treatment options. And then finally, there's still patients who've received prior chemotherapy, right? So this is not something I still do, but we still see patients who received chemotherapy. They had a terrific response some years ago. And we see them now with recurrent disease. And so what do? I'll just cover that on this slide before we go on, because that's really the simplest, right? These patients have not received any of the novel targeted therapies. So we can actually often approach them similarly to how Dr. Stevens has highlighted so far with initial therapy, although they're sort of different in that these patients do in fact have relapsed disease. So let's focus first on continuous treatment, right? And continuous therapy with a BTK inhibitor. So the first and most important question, as I highlighted, is why was it stopped? So was it stopped because of an adverse event? It turns out that if you look at all of the side effects that are associated with BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib, most of these are not because of the target itself, right? So these drugs target a protein called BTK, but they actually also target many other proteins. And these proteins seem to be responsible for a lot of the side effects that we see with these drugs. And even though they all target the same protein, they're actually all slightly different. And this is not a figure that you're supposed to memorize or know, but just to highlight each of these little bubbles represents a different protein that's targeted by one of these drugs. And just notice that each of these drugs has a slightly different pattern of what proteins that they're targeting. And so we can see differences in the safety profiles, differences even between patients in which proteins are being inhibited. And so one of the first questions is if somebody came off because of a side effect, can we simply switch to a different BTK inhibitor? And the answer is yes. And we know this from a couple of important clinical trials that were done where they took patients who were on a BTK inhibitor. Most of these patients had received prior ibrutinib, and they'd come off due to some sort of intolerance. They weren't tolerating the therapy, they had to come off of it. And now they were offered a different treatment with either in one study acalabrutinib or in the other study zanubrutinib, these second generation inhibitors. And what they found is that in the vast majority of patients, they did not experience in the majority of patients, they did not experience the same toxicity at the same severity or higher, but some did. About 20 to 30% of patients in both studies did experience the same side effect with the same severity. But really importantly, very few, just one patient in one of the studies experienced the same side effect with a higher severity. And in most cases, in the vast majority of patients, they were able to tolerate a different BTK inhibitor. So they could successfully switch to either acalabrutinib or zanubrutinib. And so we learned from this that most patients can tolerate a different BTK inhibitor if they had to come off of one due to a side effect. Of course, it's not worth the risk if the side effect was very severe or life-threatening, for example. Somebody came off of a BTK inhibitor because of a very severe toxicity. Well, that 20 to 30% risk that they're going to have the same severity of the same toxicity after switching, to me, is not something that I consider safe. And so these are patients where I would consider switching to a different type of therapy if they need to continue on treatment. It's also important to remember that sometimes we can actually try a treatment holiday. And we know this because for years, we've given patients drugs like ibrutinib, acalabrutinib, and zanubrutinib. We've had to stop therapy for one reason or the other, and we expect that the disease is going to progress, but it doesn't all the time, right? We can see durable remission sometimes in some patients when they come off treatment. This has actually been studied in a prospective study where they took a bunch of patients who were on ibrutinib, for example, for at least 6 years, and they stopped therapy, and they found that actually many patients can stay off therapy for some time. Now, this is not the standard approach. We don't just do this willy-nilly, but when patients do experience unacceptable toxicity, it's something that we can definitely consider doing. And when might you consider it? Well, if somebody's had a really good response, right? If somebody's been on therapy for a long time, they're in a very deep response. This is somebody where you might think you've got a better shot at having a longer period of time off therapy. Maybe they have lower risk disease. I'm less inclined to do this, for example, if somebody has higher genetic risk, if they've got something like that's deletion 17p that Dr. Stevens alluded to, where I worry a little bit that the disease is going to come back sooner. These are patients where I'm less inclined to trying a holiday. I'd be more inclined to trying to continue on some treatment, be it a different BTK inhibitor or a different class of therapy altogether. But just to remember that these treatment holidays are things that can be considered if we have to stop therapy for reason other than disease progression. But what if a patient progresses? So this is if somebody's had a remission on a BTK inhibitor and then their disease is progressing while they're receiving a BTK inhibitor, what is the right approach at this point? can we go to a different BTK inhibitor? Well, among the three that I've highlighted, we're going to talk about a different one in a little bit that is an option. But it turns out that acalabrutinib, zanubrutinib, and ibrutinib all hit the same target, right? So they all hit this one spot on BTK, which is really critical because it blocks BTK from interacting with other proteins, other parts of the cell. And by blocking it, it prevents BTK from doing all the things to drive the CLL to grow, to resist being killed, and to progress and cause trouble for patients, right? And so giving acalabrutinib, zanubrutinib, and ibrutinib is able to block this protein and achieve a response for patients. The problem is that if there's a resistance to one, there's resistance to all, right? So they all have the same target, which means that, say, if you have a mutation at the place that this drug is supposed to attach, it renders all of these drugs in the same group ineffective. Acalabrutinib, zanubrutinib, and ibrutinib are not effective if one of the other ones within this group had developed resistance. And so if you try switching within these different drugs, you'll find that the CLL will worsen despite switching to a different drug. And so for this reason, we don't change to a different covalent, that's these specific BTK inhibitors, BTK inhibitor, ibrutinib, acalabrutinib, or zanubrutinib, when the disease is worsening on one of them. This just won't work. Also, just a word of caution, if the disease is getting worse on one of these drugs, there is some concern that if we just stop it, the CLL can worsen more quickly. And so if the disease is progressing on a BTK inhibitor, then we typically will keep the drug on for a period of time because it's often still having some effect while we're transitioning to a different treatment. And we only stop it once we know it's safe, once we see that there's clear evidence that the CLL is starting to be controlled. But so what do we do if the disease is getting worse on a BTK inhibitor, or if there's a tolerability issue that can't be corrected by switching, or there's a tolerability issue with a BTK inhibitor that you're just not comfortable risking again, right? Well, the second line treatment in this scenario is a regimen of venetoclax, which is this drug that Dr. Stevens has described, this BCL2 inhibitor, a pill for 2 years combined with rituximab. This is the standard of care treatment for patients with previously treated CLL. This is based on this large randomized trial where this was compared against chemotherapy and demonstrated to be better with longer remission durations and also higher rates of clearing this MRD, this measurable residual disease, which also we know predicted for even longer remissions. And so this is an unequivocal standard second-line treatment option that we use in patients whose disease requires a second-line therapy after they've received one of the BTK inhibitors or another first-line treatment option. Now, I don't typically use rituximab in this setting, and that's because in the first-line setting, we've seen that using a different immune therapy, obinutuzumab, is better than using rituximab when combined with venetoclax. And although the study hasn't been repeated in the relapse setting, many CLL doctors, including myself, use obinutuzumab instead of rituximab anywhere that rituximab is being considered in CLL. And so when I give patients venetoclax to patients who require second-line treatment, I give 2 years of venetoclax typically. With the first 6 months, I also give this obinutuzumab treatment. And this is my standard second-line treatment after a BTK inhibitor. What about the other scenario? So let's switch gears to patients who receive time-limited treatment, and we'll say with venetoclax and obinutuzumab, although truthfully, what I'm going to discuss is going to apply as well to folks who might have received venetoclax with acalabrutinib with or without obinutuzumab. The same criteria would apply in that scenario. So the first question here is, patients who receive venetoclax and obinutuzumab up front, they get 1 year of venetoclax treatment. So it's a time-limited treatment with 6 months of obinutuzumab. And in most patients, the vast majority of patients, the reason that they stopped venetoclax was not because it stopped working. It's not because they weren't able to tolerate it. In most cases, it's because they simply finished treatment. And so they stopped therapy in a response. Their CLL cells were still responding to the therapy in most patients at the time that it was stopped. And so the question uh, is the CLL still susceptible to this therapy? Can we simply go back to this to try to achieve another response? And so this has been studied. The reference I forgot to include here, but this is from Dr. Thompson at Memorial Sloan Kettering. And what she did was she took some of the first patients that had received venetoclax. This is a very different situation. These were patients that had received it as the second, third, fourth line therapy. These were more previously treated patients. And they had received venetoclax the second time around, and she said, well, what is the response rate? And also, what is the durability of the response? And what she found was that in these patients, about 80% of patients, so 4 out of 5 patients, could respond a second time around of venetoclax. And when they responded, the average response was just over 2 years, suggesting that even just going back to the same treatment with venetoclax can be successful and achieve additional response duration without having to go on to a different class or something that a patient's never received before. And so anytime that I see somebody who's received prior venetoclax and obinutuzumab or venetoclax-based treatment, the first question I ask is, can I go back to it, right? And so the questions to see if this is a good idea are here. And so the first one is, how long was the patient off treatment? And the second is, how did the patient tolerate venetoclax? If the patient was off treatment for a long time, I have a lot of confidence, a lot more confidence that they're going to achieve a response a second time around. If somebody didn't tolerate venetoclax, well, this is sort of a mood issue, right? Why am I going to go back to a treatment that a patient didn't tolerate the first time just to achieve additional response when we have other options potentially in waiting? And so when do I consider retreatment? I consider it typically when somebody has had at least a 1 year period of time after stopping venetoclax and an ongoing response. Some folks use a 2 year cutoff. I think that anything over 1 year is reasonable. Um, uh, I'm less inclined again to consider this if somebody didn't tolerate venetoclax well, and if I don't feel confident that I can get them through it in a way that's acceptable, right? We've got so many great treatment options for people living with CLL. So the last thing I want to do is put somebody through a treatment that's going to make them miserable. If they didn't tolerate it well, I'm going to move on to something else. Well, if venetoclax retreatment is not an option or is not the preferred option, then we go on to BTK inhibitors, right? So these are patients that have not received these before. They've received venetoclax, obinutuzumab, or some other venetoclax combination. Um, and we go on to what's called a second generation BTK inhibitor. And so I don't use ibrutinib anymore in CLL. The reason, although it is used still frequently worldwide, and it is a very effective, very good treatment option that's got in many patients very long, durable remissions safely. However, we now have large randomized trials that have shown us that the newer drugs, acalabrutinib and zanubrutinib, are safer than ibrutinib with fewer cardiac toxicities, fewer atrial fibrillation or arrhythmia toxicities. And in the case of acalabrutinib, also less hypertension or high blood pressure, although with more headaches, and clearly showing that these are safer options for patients with relapsed CLL. And so in patients who require a different treatment after venetoclax obinutuzumab, I select either acalabrutinib or zanubrutinib. I'd highlight that zanubrutinib was also shown to be superior in terms of the durability of the response, which we measure as progression-free survival compared with ibrutinib. This doesn't mean that zanubrutinib is better than acalabrutinib. These two drugs were not directly compared, and there were some differences in the studies that make it difficult for us to say which one is better. But just to highlight that in that study was also shown to be better than ibrutinib in that group of patients. So once we have seen a patient who's received a first line of treatment and a second line of treatment, in this day and age, this really is a patient, in my mind, that has received both a BTK inhibitor, like a covalent BTK inhibitor, like ibrutinib, acalabrutinib, or zanubrutinib, and has been failed by that class, meaning that we can't go back to one of them, and uh, uh, and they've also received venetoclax-based treatment, either venetoclax or obinutuzumab or venetoclax, another combination. Now, these are the patients I consider as requiring third-line treatment. And so one option we have is a newer BTK inhibitor called pirtobrutinib. So it's a third generation BTK inhibitor, which works in a slightly different way. And why this is important is that it doesn't rely on the same target that the other BTK inhibitors rely on. So whereas we can't switch between ibrutinib, acalabrutinib, and zanubrutinib if we develop a mutation in that one spot, you can switch to pirtobrutinib because it still can have an anti-CLL effect and achieve a response in those patients. It also is a very safe drug. I'm just highlighting here on the right side here, there's a very low rates of severe side effects. And so this is a terrific option for patients with CLL, and is definitely something that we can go to in patients who either, in most cases, were not able to tolerate a BTK inhibitor, or patients who've progressed on a BTK inhibitor. These also have a very high likelihood of response. About 4 in 5 patients will have a response to this treatment, although very few patients have a complete response. That's okay because this is a continuous treatment. We continue this until it's either not working or if there's some side effect that precludes us continuing this. And but this is a continuous treatment, right? So this is not something that we give with a goal of stopping it with the current approval. The other third line treatment option we have is something called CAR T cells. And this is a fundamentally different treatment option in CLL. CAR T cells are engineered from a patient's own T cells. I usually describe it as sort of science fiction or magical, but it somehow works. We take a patient's own immune cells, their own T cells, right? These are a different type of white blood cell that's not involved by CLL. And we send them to the lab and we re-engineer them so that they can be activated to detect and then kill the CLL when it comes into contact. And when we give them back to the patients, this can go after the CLL and achieve deep responses, complete responses with actually just a single dose of therapy. It's not so simple as that. It's actually a pretty complicated process. It often requires admission to the hospital. It requires you to be within a couple hours of a major center that can do this. There is some considerable risk early on of things like infections and other side effects, like something called a neurologic toxicity, something called this sort of febrile syndrome. It's called a cytokine syndrome. But these are very manageable. We do this every day, or caring for many patients with this type of therapy, and there's a lot of experience with this. So it's something that at a major center that I think that patients can feel very confident. Nonetheless, it's still removing you from your normal life oftentimes, and it requires a major upfront logistical challenge. Now, the response rate to this treatment is less than with pirtobrutinib, and there are relatively few complete responses. It's a complicated slide, but just focus on a couple things here. About 30% of patients have these more durable remissions, right? So after just a single dose of treatment, if we go out a year, 2 years, about 30% of patients will remain in an ongoing remission at that point. That's not enough, which should be more. However, some patients have really pretty outstanding remissions, and I continue to see some of these patients. In fact, Dr. Stevens and I both cared for some of these early patients on this study who continue to come into clinic 7, 8 years out now without evidence of disease and off of any treatment, right? So for a small group of patients, too small, unfortunately, but for maybe 20, 30% of patients, about 2 to 3 out of 10 patients, this can be an outstanding long-term option for patients whose disease has behaved badly in the past, which sets us up as a very interesting decision between pirtobrutinib, right, which works in a majority of patients, but with an inevitable risk of this returning, versus liso-cel, this CAR T cell treatment, which works in a minority of patients but can have a much deeper and more durable response. For many patients, they will receive both of these drugs over time. And so the question is, which one is best first? Although there probably are some patients who have particularly durable responses to liso-cel and may not require another treatment for years. We need much more time before I'm comfortable using the word curative outcome for this treatment, although that is a question of whether CAR T cells could be potentially curative in a disease like this as well. So I'm just going to highlight some selected side effects, and I'm going to sort of breeze through a couple slides in the interest of time, but just to highlight that when we start a BTK inhibitor, it's really important to think about past medical history and other medications. Because of the bleeding risk, we have to think about their bleeding history and whether they're on blood thinners or antiplatelet drugs, which do increase the risk of major bleeding by a couple percent. We have to think about risks of prior cardiac arrhythmias, which are important. Although with the newer versions of BTK inhibitors, atrial fibrillation risk is much lower, and so this is still an option for those patients. Things like poorly controlled hypertension might sway me towards a drug like acalabrutinib, whereas things like headaches might sway me towards a drug like zanubrutinib, because this seems to be more tied to acalabrutinib. And of course, reviewing medications is just really important because any medication interaction can increase risk of side effects. Just to highlight a few in particular, cardiac arrhythmias can happen with any of the BTK inhibitors. If a patient's on ibrutinib still, they've been on it for a long time, this isn't a reason to switch maybe to acalabrutinib or zanubrutinib. These are drugs that have much lower risks of atrial fibrillation. If it's well controlled, we actually don't need to change treatment. It's really only in those patients where it's difficult to control where we sometimes change therapy. If anticoagulation is necessary to reduce stroke, as it usually is, it's important not to use Coumadin or warfarin, although that's rare anyways. I typically prefer apixaban, but one of the novel pill anticoagulants is typically preferred. In very rare circumstances, there people with more concerning arrhythmias. These are reasons to stop the drug and involve a cardiologist for certain, although these are, again, extremely uncommon. Bruising and bleeding are important risks with these drugs. Bruising, importantly, doesn't seem to predict a risk of major bleeding. And so I counsel patients that this is something that they may see. About half of patients see it, and it's not something that I typically worry about. Minor bleeding should be considered. Oftentimes it doesn't warrant any sort of change, but minor bleeding should at least lead to some discussion about risk of major bleeding. If it was a minor bleed that puts you at risk for more major bleed in the future, this should really be addressed. And major bleeding really has to be addressed with stopping the drug and making sure that the bleeding risk is reversed before resuming the drug. It's really important to hold the BTK inhibitor before and after any procedure or surgery, the same way that you would with an anticoagulant, a blood thinner, or with an antiplatelet like an aspirin. And of course, anytime there's bleeding, to go back and ask, what about all the other medicines? Maybe this changes the risk and benefit of other things like aspirin. Was it prophylactic? Was it being used because of another condition? Because this might impact the bleeding risk moving forward. There are many other side effects that we sometimes think about with these drugs. The truth is that although arrhythmias and bleeding are things that Dr. Stevens and I might worry more about, these are often the things that patients worry about. Diarrhea and rash are often self-limiting and get better, although sometimes they don't. Sometimes patients need to reduce the dose or switch the drug. Myalgias or muscle aches can be problematic. They can be pretty persistent in some folks. These usually get better with dose reductions. Sometimes they're changing the drugs to different BTK inhibitors. Headaches are important. They're very caffeine sensitive. Just remember this. If you get headaches with a BTK inhibitor, in particular acalabrutinib, you might want to add a morning coffee to your breakfast, and this can oftentimes take care of the problem. They're less common with zanubrutinib, and so this is also an option to switch the drugs. Remember that if we have to make any changes, the first question is, should we just switch to a different BTK inhibitor? And oftentimes I prefer a full dose of a different BTK inhibitor rather than reducing the first, although this is somewhat stylistic and your doctor might approach this slightly differently. When I am considering a dose reduction, I often hold the drug and then resume it at a lower dose level just to prove to myself that it's responsible for the side effect. Although sometimes I just reduce to the dose level right away. GI side effects. So just moving on to venetoclax side effects. GI side effects like diarrhea can happen with some frequency. Um, uh, Venetoclax is given as a pill. You typically take it about half an hour after you eat something, usually in the morning. So the first question I ask is, what are you eating? Sometimes people need to have a little bit more to eat or slightly different. And sometimes if this is persistent and there's not a lot of rhyme or reason, I ask patients to keep a food diary, and this can be helpful. Timing is really helpful often. So when people have ongoing GI side effects despite changes in what they eat, sometimes I'll switch it to dosing in the evening after dinner, and this often takes care of it. And then again, sometimes we just have to modify the dose or give other supportive meds to prevent this as well. It's going to highlight neutropenia, low infection fighting white blood cells or neutrophils. This happens actually with any of the drugs that we're talking about. And so this guidance actually really applies both to BTK inhibitors, but also to venetoclax. When patients are receiving these drugs and their neutrophils are low, again, these are their infection-fighting white blood cells that are responsible for protecting us against many bacterial infections and others. Sometimes there's an interest in just stopping the drug and trying to see if it gets better. I usually don't do this unless there's a fever or an infection. And if somebody has no fever, no infection, and their infection-fighting neutrophils are low, typically we can just treat through, continue the treatment with a booster shot called Neupogen or Granix or Filgrastim or Neulasta or others to boost up these white blood cells that allows us to stay on treatment. Especially early on treatment, this is actually really important because the best thing to improve the neutrophils may be improving the bone marrow so that it's healthier, stronger, and can withstand continued treatment. And so stopping the treatment can actually sometimes work against us. And of course, if somebody's got a fever or they have an infection, it's very important to stop this drug and provide routine standard care to treat the infection and get them through it. Tumor lysis syndrome is a thing that we all think about with venetoclax. This is when there's rapid death of the CLL and the cells they sort of explode and the salts and acids from within go into the blood, and this can hurt the heart, the lungs. It can cause a whole lot of trouble. The truth is that ever since instituting this program that's highlighted here, the true risk of tumor lysis syndrome with venetoclax is actually fairly low. We're very good at preventing and mitigating this risk. And so this involves assessing the risk of tumor lysis, doing preventive measures like hydration and medicines to lower certain acids in the blood, and then doing a slow titration of the dose over 5 weeks, which allows gradual tumor reduction or disease reduction to reduce this risk. One little trick just to highlight, I have many patients that tell me that they're awake all night peeing. You don't have to do this throughout the day. It's okay to drink as much as you can early on so that by the time you go to bed, you're ready for a good night's sleep. So I'm just going to say thank you. And just on the closing slide, just highlight that, the Lymphoma Research Foundation was very kind to support a workshop in the last year that Dr. Stevens and I had the pleasure of leading to really put together these decisions into a single document that we hope is helpful both to doctors and clinicians, but also to patients. And on the Lymphoma Research Foundation website, there's summaries of these recommendations as well, which I hope can be helpful to folks. Thank you.
Get into some questions that we received. So jumping right into it, Dr. Stevens, what is the significance of monoclonal IgG as the first symptom of CLL before any ALC elevation?
This is a good question, and I will see this in folks that have CLL. And basically, your lymphocytes, there's a type of cell that, as the cells mature, it changes into a plasma cell. But somewhere in between, those cells are the ones that start making antibodies. So an IgG is an antibody. And often the CLL cells itself are making these abnormal antibodies. And so sometimes those can be the first things that are picked up on labs, just because maybe somebody has some neuropathy or some pain in their legs, or maybe you can see an elevated protein on general labs, and so they check and they find this monoclonal protein, and they might call it. There's a condition called MGS, or monoclonal gammopathy of unknown significance. And then sometimes people might say, oh, you have an IgG MGUS or something like that. But really, when it gets down to it, you diagnose the CLL, and often you can tell, if they express the same kappa or lambda light chain, it's probably coming from the CLL. And a lot of times it doesn't cause too many problems, as long as it's not a super high level of this protein. Super high levels can lead to things like neuropathy or other changes. But it is possible for people also to have two separate kind of cancer clones that are growing. And so sometimes if I'm really trying to tell, is that monoclonal protein related to CLL versus CLL plus another clone, you actually a lot of times will have to do a bone marrow biopsy to figure that out. It becomes important, like if you want to do a treatment, maybe that somebody needs treatment for this neuropathy, you might want to narrow it down and just make sure you're treating the right thing. And sometimes a bone marrow is required to do that.
Thank you, Dr. Stevens. And Dr. Soumerai, if an otherwise healthy 65-year-old male has CLL that's returned after being successfully treated and in remission for 14 years, do you consider this case as a relapsed CLL or a new patient when deciding on treatment?
So I still consider this as a relapsed disease. We do know that some of these, I have patients that have had outstanding remissions to prior chemotherapy or prior targeted treatments many years ago. And that is certainly a good thing. It speaks to a favorable prognosis. Probably we actually know that that being in a longer remission to the prior treatment actually was clearly prognostic for patients who required subsequent treatment. So that's certainly a good thing, but it would be considered relapse disease. That said, as we said before, I think of patients who've only had chemotherapy in a sort of a different light because they've really not been exposed to any of the treatments I would really consider standard first-line treatments and beyond in the modern era.
Thank you. And Dr. Stevens, would you be able to speak at all to the anecdotal use of cordyceps tea, which for anyone who doesn't know is it's a medical mushroom, by CLL patients, and any of the results that they've been seeing and any of this possible application?
Yeah, this is a good question. I've been hearing a lot about this lately, and as you mentioned, this is a mushroom that I think originally was grown in China, and so used in some Chinese medicine uh, uh, for the purposes of treatment of multiple different conditions. And kind of when you break it down, the extract of this mushroom actually is something called a purine analog, which is actually the same type of drug that fludarabine, one of these classic chemotherapy drugs that we have just talked about. And so it may be possible, there are some very preliminary data saying, should this be used in the treatment of CLL? But it may be that it's just form of chemotherapy that's not quite as refined as we have fludarabine. So it might be doing some of the same things that fludarabine did, but one thing that's kind of unique about it is there is some evidence that it might help to boost the rest of the immune system, like the T cell function and other parts of the immune system that are really important to helping fight off CLL. And so I think it's definitely a really interesting question. Would I tell everybody to run out and get supplements and start using them immediately? No, I wouldn't, just because I think there's a lot more that needs to be researched to figure out the safety of these compounds. And unfortunately, a lot of people will kind of take a small piece of research and run with it and market it to a lot of people. And I think it's a really good idea, and I think it's great that there are a lot of researchers looking at, its impact on CLL cells in the lab. There's even people looking at mouse models of CLL and how does it help to treat CLL. I think there just needs to be a lot more research before we recommend it, but I certainly think it's an interesting compound.
Thank you. And Dr. Soumerai, how can you tell if you're relapsing? How many blood tests over what period of time are needed to show increased lymphocyte count? And how do you know if lymph nodes are due to CLL and not an infection? And this person is wondering if a CT is always mandatory.
I think these are very good questions. And I'm actually going to pull out a couple of questions from within that. I think that the first question is sort of what is the right way to monitor for CLL, SLL recurrence? So the truth is that CT imaging is not necessary in most patients in most scenarios, unless we're starting treatment or we're assessing response. I oftentimes do a CAT scan. I typically do it at diagnosis in patients who have palpable nodes, lymph nodes that I can touch, or spleen that I can touch. I do that because I like a baseline. I want that information for the future, something to compare against. But some of my colleagues don't. Some people only get it if there's a symptom or some other reason to do this. I also do the same thing at the end of treatments if I'm stopping a treatment to have a new baseline as well to assess response and to be able to compare against it. But in routine monitoring, I usually just do blood work and a good physical exam. Um, uh, and uh, and the one thing about CLL that's helpful is that in most scenarios we can detect the lymph nodes on exam if there's going to be any significant lymph nodes anywhere else. And so we can detect any change there and then only get imaging if there's a symptom that really requires it. I'd say that the one exception is in patients who have where we call it the small lymphocytic lymphoma or the SLL, where it really always was just in the lymph nodes and spleen. And these are patients where I sometimes get additional surveillance imaging over time, but that's really sort of a case by case basis. The other question I think is how do you know that it's a CLL and not an infection? That is sometimes a hard one. It's not uncommon to be called by somebody in the emergency department because the white count is now 200,000 and it was just 10,000 last week. And so obviously it's an explosive disease, but it's often not. We know that the blood counts and the lymph nodes can have these very exuberant responses to infections. And so I really try not to respond to a single point in time. And so these are patients where we will often repeat the testing or repeat an exam a couple weeks or even a month or two out, unless there's other evidence that the disease is clearly worsening. And it all really goes into the context and it depends on the specific situation with the patient.
Thank you very much. And I'm going to sneak in one more question here for Dr. Stevens because I think it's a question a lot of our constituents have. How does the age of an otherwise healthy patient enter into the treatment choice, specifically those 75 and older? And they note that, second line treatment could come up when they're at age 80, for example.
Yeah, this is a great question. And I was just reading through and I'm sorry, it looks like we're probably not gonna have time to get to all the questions because there are some really great and really smart questions that people have posed. So first of all, I commend you all for asking such great questions. But the question about how does age impact treatment? It impacts treatment a lot less than it used to when we really had all the standard chemotherapy drugs that were really toxic. We kind of thought, well, if somebody's younger, we might do these more aggressive chemotherapies. If they're older, that wouldn't be an option. But all the BTK inhibitors, the venetoclax, all of that, there's no real age limit in my mind. And so for me, it's more about general health of the person and including what are the other medical problems that they have. Do their kidneys work well? Do they have any other bleeding risk, or they're on blood thinners, things like that? That's more impactful to me than the actual age of someone, which is really kind of a nice feature. I would say that the only place that maybe doesn't apply so much is for things like cellular therapy. So it's really rare that we would recommend a bone marrow transplant for somebody with CLL now, but that's one where someone else donates their cells. And it's a really aggressive procedure and probably above age 65 or so, and that's kind of flexible. I generally consider it to be just too toxic for people who are older than that. But I would say the majority of treatments, and I mean, even CAR T that Dr. Soumerai talked about, which sounds like a more aggressive therapy. I mean, people I've successfully and safely given that to folks who are in their 80s, who are otherwise healthy. And so really, it's kind of nice because age doesn't really impact my treatment decisions as much as it used to.
Great to hear. Thank you so much, Dr. Stevens, and again, Dr. Soumerai, for your time today. And just want to wrap up by saying, yes, we do have quite a few questions left over. Our helpline is always available to you. Their information can be found at lymphoma.org. The number for the helpline is 800-500-9976. And the email is helpline@lymphoma.org. But again, that's on all of our materials. I did send a link in the chat to access our fact sheets and our lymphoma booklet, which has information on CLL. And then our fact sheets, we have one on CLL and one on relapse refractory CLL. In terms of upcoming programming, I mentioned our lymphoma talks in Minneapolis, Houston, and Los Angeles, and those will have specific CLL sessions. We also have upcoming virtual programming. We'll have our educational forum in the fall, which is virtual, and we'll have specific sessions on CLL as well as some of these treatment options. But just wanted to reiterate, thank you so much again, Dr. Stevens and Dr. Soumerai.
Yeah, thanks for asking, and thanks for hosting all these great programs.
Thank you very
Yes.
much.
Have a great rest of your day. Thank you. Take care, everyone.